Alrighty, good afternoon and welcome to our series of webinars focused on bringing you information about COVID-19 related topics. My name is Casey Stevens and I'm a communication specialist here at Quality Insights. Today, we are going to be focusing on the minimum data set changes are coming, sections G, GG, H, and I. Everyone has entered the meeting on mute, but we will have discussion following the presentation. If you have any questions or comments, please submit them either using the chat or the Q&A tool in your Zoom menu. You can also raise your hand to request to be unmuted to ask your question aloud. We invite you to join us every Wednesday at 2 p.m. for more of our weekly webinars. Next week, we'll be discussing the MDS changes and highlight sections J, K, L, and M. And now I'd like to introduce our guest today, Deborah Wright. Deborah is a quality improvement specialist at Quality Insights. She joined our team after being in the long-term care industry for more than 30 years. She has a wealth of experience in long-term care and nursing management, ranging from certified nurse assistant to vice president of healthcare operations. She's most passionate when she's working with the MDS process and quality improvement. Deb, thanks for joining us today.
Thanks, Casey. So I am going to stop my video here and share my screen. All right. So like Casey said, we're going to talk, section G is not on the new federal MDS. I just have a couple things I want to touch base with that. And then we'll go into section GG, H, and I. So just a recap from all the other weeks that we've done, here are the links to the MDS forms and the REI manual. The REI manual is still in draft form, but the forms are finalized. And here's also a link to CMS's official YouTube channel where they have a variety of different trainings, but here are some examples of training sites that they have for the MDS. Some overall changes to the REI manual. They made a lot of the language is now gender neutral. There's minor updates to wording to enhance better understanding. They've improved some clarity. All the references to keys have been changed to I keys, and they made revisions pertaining to the legal proxy information for family members and significant others. There's been revisions to the chapter guidance for chapters 1, 2, and 4. We're not reviewing those, but just so you're aware that those changes have been made. And then here's a list of the data elements that are either new or revised in the guidance for chapter 3. So getting into where we left off. So section G, this is just an FYI. Section G is not on the new federal MDS that's going into effect October 1st. However, depending on your state, there are some sections that still will be required on the OSA. So it's again removed from the federally required MDS, and most of the items have either been retired or moved into section GG. So GG, our favorite section, functional abilities and goals. The intent of this section is to include items about the residents' functional abilities and goals. It focuses on their prior level of function, their function at admission for their baseline, and then their function for their discharge performance. We're going to identify discharge goals. We're going to look at the performance throughout a resident's stay, their mobility devices, and their range of motion. That's all been pulled in from section G. And then the functional status is assessed based on the need for the assistance when performing that self-care and mobility activities. So what data elements have been moved from G and incorporated into GG? We're going to be looking at the ADL assistance, bathing, balance during transfers and walking, and their rehab potential. Section G data elements that were added to GG also include the functional limitation and range of motion, mobility devices, personal hygiene, bathing. This is where they've taken that tub shower transfer aspect and moved it into section GG. And depending on the type of assessment, the data elements are going to differ. So whether we're doing an admission GG, a discharge, or an OBRA or an IPA assessment. So prior functioning, just a little clarification in this. Overall, this section hasn't changed too much. It is still only completed on the PPS 5-day. The clarification that they had was mainly related to steps, in that the stair activity indicates that a resident went up and down their stairs by any safe means. So if they are using an assistive device or any kind of equipment, whether it's a walker, a cane, even a stair lift, how did they get up and down those steps and what level of assistance? They did clarify, though, that going up and down a ramp, if you've installed a ramp, that does not count as going up and down steps. Limitation and range of motion, it's the exact same that we had in section G. They've just moved it into GG, upper and lower extremities. They defined it, that's a limited ability to move a joint that interferes with daily functioning, particularly with activities of daily living, or places the resident at risk. And they gave lots of coding tips and examples are in the RAI manual. Mobility devices, again, this is exactly what we had in G. They've just moved it into GG. So the look back periods. So took me a little bit to pull this all together, but basically what they're saying is we now have 3 different sections for the GG. We have our PPS admission, we have OBRA assessments, and we have discharge assessments where we're going to be doing GG. So a standalone 5-day Medicare Part A admission, we're going to be looking at the first 3 days of the Part A stay. An OBRA admission, so they're not on Medicare Part A, and it's just a regular OBRA admission assessment. That never was really truly clarified in what we're doing now. But they've clarified it now that it is the first 3 days of the stay, starting with the entry date. So if we're combining it with the 5-day, the look back period is still the first 3 days. Technically, which probably a lot of facilities were not doing, is if it was a standalone OBRA admission, we should have been looking at the ARD back 2 days because it was an OBRA assessment. But now they've now clarified that, so it's all the same. And if it's a standalone Medicare Part A, or if it's an OBRA admission, we're looking at that first 3 days of the stay for our look back period. If it's an IPA assessment, we're looking at the ARD and 2 previous days. If it's a Part A discharge, just like before, we're looking at the end of the Medicare stay and 2 previous days. And if it's an OBRA discharge or an OBRA other than the admission, we are looking at either the discharge date or the ARD date plus 2 previous days. So this is just some screenshots to show that there's 3 different sections now for self-care for admission, self-care for discharge, and self-care for an OBRA or an interim MDS. And the same thing for the mobility. We have the mobility 3-day admission, mobility 3-day discharge, and mobility for an OBRA or an interim MDS. So for the admission functional assessment, they gave a little bit of a clarification with this, in that the admission assessment should be completed for the benefit services in order to reflect the resident's true admission baseline function. So what is their baseline function when they came into the facility? So that's why we're looking at the first 3 days, whether it's a Medicare PPS or an OBRA admission. What was their baseline when they came in to the facility? And they further identified and defined that prior to benefit of services means prior to provision of any care that we as the facility would be resulting in their independent coding. So we want to be able to treat them and give them the services that they need and still identify what their baseline function is. For the discharge, we are going to code with each admission assessment when there's a start of a PPS stay. Discharge goals are not required when it's a standalone OBRA assessment. So we're only doing that discharge goal with the PPS stay because for the SNF quality reporting program, a minimum of one self-care or mobility goal must be coded. Now, as a facility, you can choose to complete more than one self-care or mobility discharge goal, but you must have at least one. And obviously, the more that you identify and the more you're working with the resident, the more it reflects their true status and helps individualize their care and their care planning. So just to go through the coding instructions, for the most part, this has not changed. They've added a couple clarifications, but that hasn't changed. So just to review the coding, because it is so much different than Section G, we're going to code 6 independent if the resident completes the activity by themselves with no assistance from a helper. We're going to code 5 setup or cleanup assistance if the helper provides that setup or cleanup, but the resident completes the activity. So the helper and the staff only assist prior to or following the activity, but not during the activity. So if we're providing them with their hygiene items, or we're opening a food container, or we're giving them their assistive device, but once we do all that, they're able to do the activity, then we would code 5 for that setup. We'll code 4 for supervision or touching assistant if the helper provides verbal cues or touching, steadying, contact guard assistance as the resident completes the activity. This assistance can be in a number of different forms. It can be intermittently or throughout the entire activity. It could be verbal cues, general supervision. We're also going to code supervision if the resident requires only verbal cues to complete the activity safely. So if they're doing the entire activity, but throughout the activity, we're supervising them and we're giving them verbal cues, then we're going to want to code 4 for that. We're going to code 3 for partial or moderate assistance if the helper does less than half the effort. And we're going to code 2 if the helper does more than half the effort. And then dependent, this is one that I think a lot of people tend to code incorrectly or miss the opportunity to code. This is when the helper does all of the effort, or even if the resident assists with the activity, it takes 2 helpers to complete the activity. So if they are transferring and there's 2 helpers on each side of the resident to do that transfer, then we're coding dependent, even though the resident did transfer from bed to chair by themselves. But if we were there with them and helping them, then we would code 1 for dependent because there were 2 helpers with them. And then these codes haven't changed any. We'll code 7 if the resident refused. We'll code 9 if the activity wasn't applicable for them. We would code 10 if we didn't attempt due to environmental limitations. And we would code 88 if we didn't attempt due to medical condition or safety concerns. And then here's just the decision tree to walk you through which level of assistance. And what we're going to do now for the rest of Section GG, we could talk about Section GG all day. But so for this short period that we have today, I'm only going to talk about the coding tips that were added to Section G. Other than that, everything that was in Section G prior is still there. We're just adding some additional coding tips, and that's what we're going to review today. So for eating under self-care, they added that eating is to assess the resident's ability to use suitable utensils to bring the food or liquid to their mouth and swallow the food, or once the meal is placed in their food before the resident, is placed before the resident. So that was the coding tip for eating. For oral hygiene, they added clarification if the resident is edentulous, we would still code oral hygiene based on the amount of assistance that it required the helper to clean the resident's gums. Toileting hygiene, they included performing perineal hygiene, managing their clothing, such as before and after voiding or having a bowel movement, and adjusting the clothes relevant to the individual resident. Shower and bathing self, they added that this could be from any location, whether they were getting a bed bath, whether we were assisting them to a tub bench, and we would code 5 if we did the setup or cleanup assistance, if the resident completed the bathing task after we retrieved the supplies and provided the necessary setup for them. Dressing, if a resident requires assistance with dressing, including assistance from buttons, fasteners, fastening a bra, code based on the type and amount of assistance required to complete the entire dressing activity. So they just clarified that there a little bit. Personal hygiene, they added that personal hygiene involves the ability to maintain personal hygiene, including combing their hair, shaving, makeup, washing and drying their face and hands, but it does not include baths, showers, and oral hygiene. So it's all those other things, and personal hygiene would not be included in a standalone PPS, but all the other types. Under mobility, they added rolling left to right. If the resident doesn't sleep in bed, they clarified that we should assess bed mobility activities using the alternate furniture on which the resident sleeps. So maybe rolling left and right is shifting their weight left to right as they're in their recliner chair or whatever they're using to sleep in. Lying to sitting on the side of the bed. Remember before, part of the definition was the resident's feet had to touch the floor in order to perform that task. They've taken that piece out of it. So it's still lying to sitting on the side of the bed, but they removed the residents touching the feet part. Sit to stand. The activity includes the resident coming to a full standing position from any sitting surface. And they added clarification that if the full body lift, such as a Hoyer lift, mechanical lift, is used to assist in transferring a resident for a bed to chair transfer, we would code that this activity did not occur. Chair to bed to chair transfer. They clarified this, that the transfer can be a stand pivot, squat pivot, or a slide board transfer. So we would start the assessment with the resident sitting at the edge of the bed or their alternative sleeping surfaces, and ends with the resident sitting in a chair or wheelchair. They further clarified it that when possible, the transfer should be assessed in an environmental situation in which taking more than a few steps would not be necessary to complete the transfer. So you want to have wherever they are transferring, whatever chair they're transferring to from bed, you want to have that chair as close to the bed as possible. Toilet transfer includes the resident's ability to get on and off the toilet with or without a raised toilet seat or a bedside commode. So whatever they're using for their toileting, that's what we would look at. And we're looking at the process. We're looking at the hygiene, clothing management, and transferring on and off a bedpan are not considered part of a toilet transfer. So we can use the toilet, we can use the bedside commode, we can have a raised toilet seat, but the bedpan is not considered part of this. And then we would code 5 if the resident requires a helper to position, set up on the bedside commode before and after in those activities. If they do not require assistance during the toilet transfer, we would code 5 for setup and cleanup assistance. Tub shower transfer involves the ability to get in and out of the tub or shower. We're not going to include the washing, rinsing, drying, or any other bathing activities in this item. We're just focusing on the transfer. And if the resident does not get in out of the tub or the shower, then we would code the appropriate activity did not occur, either refused, not applicable, or didn't for their safety interventions. Car transfer, they clarified that this does not include getting to or from the vehicle, doesn't include opening and closing the door, and doesn't include fastening or unfastening the seatbelt. It's basically just the transfer from their wheelchair or walking to the vehicle and actually getting in the vehicle. If the resident remains in a wheelchair and does not transfer in and out of a car or a van seat, then we would code the activity as activity not attempted, whichever one the appropriate one is for them. Walking starts once the resident is in a standing position. So we're not going to include that from the sit to the stand because we've already addressed that. This is just the actual physical movement of walking. So a walking activity cannot be completed without some level of the resident participation, and the helper cannot complete a walking activity for a resident. Not really sure what that means. I can visualize it, but they further clarified it, so they must have had some questions with that. During a walking activity, a resident may be able to take a break. So if they need to sit and rest, then we would consider the activity that it didn't happen or they couldn't complete it, but they are able to take a brief standing rest. So if they get so far, because they're doing the 150 feet and after 75 feet, they just are like, they have to take a little breath, that's okay. But if they actually have to sit to rest to finish the activity, then we would code the appropriate unable to complete activity code. They further stated that we can use our clinical judgment to determine how the resident assessment of walking is conducting. We can do a combination of multiple walking activities to determine the type and amount of assistance needed for each individual activity. And this just says the same thing. 1 step, 4 steps, 12 steps, completing the stair activities indicates that a resident goes up and down the stairs by any safe means with or without any assistive device. So they just made this match what they were saying in the prior functioning example and clarification, that whatever device they need to get up and down the steps in a safe manner, we can count that as we're looking at the level of assistance. Getting to and from the stairs is not included when coding the curb or step activities. Ascending and descending the stairs does not have to occur sequentially or during one session. If the assessment of going up the stairs and then down the stairs occurs sequentially, the resident may take a standing or seated rest break between ascending and descending the 4 steps or 12 steps. A resident who uses a wheelchair may be assessed going up and down the steps in a wheelchair, and we would just code based on the type and amount of assistance required from the helper. And if at the time of the assessment, the resident is unable to complete the activity because of a physician prescribed restriction, for instance, the no stair climbing for 2 weeks, but could perform this activity prior to the current illness, then we would code 88 not attempted due to medical conditions. And I think what they were getting at with this is if they didn't have to do steps when they were discharged, we would code this as not applicable. So this is where they're trying to determine, do they have to do steps and they just can't because of medical condition, or do they not need to have to do steps? Picking up an object. They further add more to coding tips for this one, that the activity includes the resident bending or stooping from a standing position to pick up a small object from the floor. So picking up the object must be assessed while the resident is in a standing position. If the resident is not able to stand, the activity did not occur and the appropriate activity not attempted code would be used. If a resident is in the standing position and unable to pick up the small object from the floor and requires assistance, we would code based on how much assistance we gave them to pick up the object. They can use assistive devices. So if they're in a standing position and they have a reacher and they use that reacher and they're able to pick up the object, then again, we would just code based on the assistance that was provided. All the wheelchair items under mobility, if the resident uses a wheelchair for self-mobilization prior to admission to the facility, we would code yes to open up the rest of the wheelchair items. So the admission assessment could indicate that the resident does not use a wheelchair, but subsequent assessments could indicate that they used a wheelchair. So if we're doing that admission assessment and they didn't use a wheelchair before, they're saying we should code no. But then if they become wheelchair bound and they're using a wheelchair for the mobility, then the subsequent assessments, we would start coding the wheelchair. So that was an awful lot for section G. And I feel like if you are new to the MDS, it could be very confusing. Those were just the changes that were added in this version of the RAI. So section H, not much changes here. Bladder and bowel, here's the intent. The coding tips, they further clarified that the one-time catheterization for urine specimens, which we knew we couldn't code, they've also added that one-time catheterizations for the post-void residuals, we should not be coding those as one-time catheterizations. They also added a definition for stress incontinence. And then active diagnoses, not much has changed here as well. Here's the intent. Coding instructions haven't changed. The one coding instruction that they added is when an acute condition is the primary reason for the resident's SNF stay. It can be coded at I0020B. However, in a lot of times, it's more common that a resident presents to the SNF for care related to an after effect of a disease, condition, or injury. So a lot of times that subsequent encounter or sequela codes would be what's used. So maybe they are just coming in for a UTI because they're weekend and then they're going to go back home, but maybe that's a UTI and dementia and post CVA. That's what it means. Like, figure out what's the biggest reason for why they are coming to the facility or at the facility. And then they added the example, we've all been, hearing and talking about the schizophrenia and those audits that are coming. So the example that they added is this resident was admitted without a diagnosis of schizophrenia. After admission, the resident is prescribed an antipsychotic medication for schizophrenia by the primary care physician. However, the resident's medical record includes no documentation of a detailed evaluation by an appropriate practitioner of the resident's mental, physical, psychosocial, and functional status, and persistent behaviors for 6 months prior to the start of the antipsychotic medication in accordance with the professional standards. So that's an awful lot of detail that has to be met for that diagnosis of schizophrenia now. So coding schizophrenia at I-6000 would not be coded. And the rationale is because although the resident has that physician diagnosis and is receiving that antipsychotic medication, it would not be appropriate to code because of the lack of documentation of that detailed evaluation in accordance with the professional standards. It lacks the resident's mental, physical, psychosocial, functional status, and the persistent behaviors for the time period required of that 6 months prior to the start of the antipsychotic medication. And here are just the same resources from the beginning of the slide for the RAI manual, the MDS forms, and the YouTube channel. So at this time, if there's not any questions, I will turn it back over to Casey.
Awesome. Thank you so much, Deb. In a moment, we'll begin the Q&A portion of the webinar. If you have a question or comment, please submit them either using the chat or the Q&A tool in your Zoom menu. You can also raise your hand and request to be unmuted to ask your question aloud. I'd like to again invite everyone to next week's webinar, which will discuss MDS changes in sections J, K, L, and M. That webinar will be next Wednesday at 2 p.m. and I will drop a link to register for that in the chat. We also invite you to bring your questions to our virtual live chats every Tuesday and Thursday at noon. Deborah Wright will be there to answer your questions about topics such as quality improvement initiatives, infection control, and MDS coding. You can find the links to those live chats and our webinars in the newsletter we send out each Friday called the Last Minute Lowdown. And if you'd like to receive that newsletter and don't think you're on the mailing list, you can send me an email at kstevens@qualityinsights.org. I'll also put that in the chat. and I'll make sure to get you on the mailing list. Alrighty, let's check out, see if there are any questions here for Deb. We've got a first one. For an end of a PPS assessment, do I need an OSA?
So if it, first of all, West Virginia has not made a decision yet for their OSA. So my answer is not going to be pertinent to West Virginia. So for Pennsylvania, Pennsylvania is doing the OSA. And if you're a facility that is duly certified in Medicare and Medicaid, for every OBRA and PPS assessment, except with discharge and entry MDSs, yes, we will need to do an OSA.
So we've got another question here. If a resident is admitted with a diagnosis of schizophrenia and on long-term antipsychotics, how would we know the behaviors in the 6 months preceding the medication start? Is that up to the physician to document?
Okay, so I'm going to do a disclaimer that I am not an expert in this particular area. However, based just looking at the definition, I would say that if they have significant behaviors for the past 6 months, there is going to be some kind of physician documentation, whether it's from the PCP or a psychologist that's following them, that you should be able to have that proof of the documentation to identify that 6 month proceeding.
Fantastic. Thank you, Deb. I'll see if any other questions roll in here for a moment. Alrighty, it looks like that's it for questions. Before we sign off, we'd like to ask everyone here today to please answer a short evaluation of today's webinar. The evaluation is anonymous and will show as a pop-up as the webinar ends. If you have a couple minutes to fill that out, we'd greatly appreciate it. Deb, again, thanks for joining us today, and thank all of you for joining us. We hope that we can see you again next week.
Thank you.